Hello, welcome to Whiteboard Learning. Today we're going to do adrenal disorders, which are some of my favorite disorders, if they go in the critical care way, not the internal medicine way. But anyway, let's start with the beginning of this, which is the adrenal glands, which when you look at them, here's a kidney, here's a kidney. The adrenal glands live right up near the kidney, and they are not connected to the kidney, but they are connected to the bloodstream. So they are a hormone gland, meaning they're a gland that receives hormones from somewhere else in the body. And that somewhere else in the body is in the brain, so my terrible little brain. So in directly from the brain, the pituitary here, there's a hormone called ACTH that is secreted. That's adrenocorticotropic hormone. Adrenal, cortico, meaning for the cortex, which we'll get into. Trophic, meaning growing it or making it bigger. And then hormone. So that is secreted by the pituitary. And that stimulates the adrenal gland. And then the adrenal gland has a few hormones, including cortisol and aldosterone. And those are secreted, and they actually go back and will give negative feedback saying, okay, there's plenty of hormone around. But the ACTH is stimulated by secretion of another hormone to the pituitary called CRH. And CRH is corticotropin releasing hormone. So it releases ACTH, whose other name is corticotropin. So CRH is released from the hypothalamus, and that goes to the pituitary. And then that goes to the adrenal gland. And then if you produce one of these drugs, they feed back and they say, we're pretty good. Or something that they affect, like aldosterone affects potassium. So that might feed back and say, what's going on. So this is all positive here, but this is negative here. So it's positive. So that's a positive feedback in the negative feedback loop. That this is positive and then negatively feeds back. So when there's a problem with the adrenal gland, it could either happen at the level of the adrenal gland, that's called a primary adrenal disease, or it could happen at the level of the pituitary, or it could happen at the level of the hypothalamus to cause disease. And that's most important for when you have Cushing's disease. And some of you have heard of pituitary-dependent Cushing's. And so that is when the pituitary is actually overproducing ACTH to stimulate the adrenal glands. But sometimes there can be an adrenal tumor that is secreting cortisol, and then this little guy will be small because there actually will be so much feedback that the pituitary stops producing its own, or the hypothalamus says stop, but this tumor is producing, so the ACTH actually stops. So in Addison's, which is low production, so Cushing's is overproduction of cortisol. Addison's is lack of production of cortisol, plus or minus aldosterone. We'll get into that. The Addison's can be from a primary brain disease. We always think about it as, you kind of think about the adrenal glands get atrophied and scarred, but it can be if you have head trauma. And there are head trauma humans who become Addisonian because it breaks there because of the shape of our heads. So let's talk a little bit more about the adrenal glands themselves once you see sort of how the messages are sent to produce things in the adrenal gland. Why is the adrenal gland important? It makes a lot of hormones and chemicals that are really important for us. And so if we think about it in total as a gland, it has, just like the kidney, a cortex and a medulla. Now the medulla makes things like norepi and epi, so it makes catecholamines, but it's not the only place that makes those. So if you destroy the medulla, you're not deficient in catecholamines. So luckily there's redundancy. But the cortex is very important. It's got 3 layers. One is bigger than the others. So the first layer is the glomerulosa. And the second layer here is the biggest layer, is the fasciculata. and then the third layer is the reticularis. So the easy ways to remember that is GFR. Like the kidney too. There's a GFR associated with the kidney. So GFR. Other people like to remember it by salt, sugar, sex. And the reason that that is helpful is that the glomerulosa makes aldosterone. And aldosterone is very important in your regulation of sodium, potassium at the level of the kidneys. And then the fasciculata makes cortisol, which handles sugar. Cortisol is opposite of insulin. So if insulin drives down your sugar in your bloodstream, cortisol actually is opposite and will increase your sugar. So that's just a cute little name for that. And reticularis makes sex hormones, androgens. You may have heard of androgens, but that's basically less of a problem in our patients because we don't really have, we have more spayed and neutered patients than like in humans. But that is where a lot of sex hormones are made. So people like the salt, sugar, sex. Kind of helps you remember what the different sections make. But generally that's the cortex and it's the most important part. So when you get growth of a section, you might have a tumor of the cells, of these cells, and that'll make too much. If you have immune-mediated destruction of the cells, the adrenal gland will just get more and more shrunk, and so it'll start just having thin layers of all these things and the little medulla, and it'll get much, much smaller to the point where it stops making hormones at all. And so just like scar tissue, this is just filling up and degenerating and getting destroyed. And so you'll no longer have these compounds. The one thing that we sort of didn't talk about when we talked about what affects this, and so this is affected by ACTH and some other hormones that affect aldosterone. ACTH generally mostly affects the fasciculata to make more cortisol, is, when it's coming from the hypothalamus to the pituitary with CRH, and that makes ACTH, as I was just writing. We didn't talk about kind of the third part of that loop, which is when they make these hormones and they go to the cell. So we talked about feedback loops. We didn't talk about what happens when it goes to the cell. All these hormones go to specific cells to have actions. And that's part of one of the things that we'll talk about more with critical illness. But this isn't a closed loop, and so you do have to remember that there's this loop of feedback, but these hormones go and do something somewhere else, and those cells might also feed back to give part of this feedback loop. And that's a little bit of what we talk about with critical illness associated diseases where we give steroids to septic patients, is a little bit about action at the cells. So the main disease that I like talking about with adrenal disorders is Addison's, because internal medicine does most of the cushingoid patients, and that makes me happy. I'm fine with that. So we talked about primary Addison's at the level of the adrenal gland, and so that is when the adrenal glands both stop making cortisol or plus or minus aldosterone. And I like to kind of say it is the corticosteroids and the mineralocorticoids, because that's what you call aldosterone. So a Addisonian will stop production of these things. There are diseases where sometimes the aldosterone is present, but the cortisol you might have not the cortisol and have aldosterone, and those are called atypical Addisons. But you could have it the other way, where you just lose aldosterone and keep your cortisol. That's pretty rare, though. It doesn't happen very often at all. And generally, the worry used to be that if you were one of these adrenal glands where you only lost one of these and were atypical, that in about 6 months you would become atypical. So let's go over that again. So a typical Addisonian has lost their corticosteroids and their mineralocorticoids. So they've lost cortisol and they've lost aldosterone. So what does that do? Well, aldosterone is very important for losing potassium. So it goes to the renal tubule and it helps you lose potassium because it's toxic for your body. So you want to lose potassium. It's also really important for helping you maintain blood pressure and hydration. So your volume of your blood, because it's not only affecting potassium, but secondarily you keep sodium. And we know that sodium and water are very linked, right? We did that before. So corticosteroids, they help you with maintaining your sugar. They also help you with maintaining your blood pressure. They help you get enough nutrients for things, and they help you with your gut. And so they will help your gut grow. And we're not talking about, you're saying to yourself, oh, I thought steroids caused ulcers. Well, they do when they're in large amount, but when these are these physiologic amounts of these things, and physiologic is much smaller. So you have kind of a scale, physiologic for steroids, and then you have anti-inflammatory, and then you have immune suppressant. So certainly you want to think about that when you're thinking about steroids. It's almost 3 different drugs, but we're talking about physiologic doses of these things in the body and what they do regularly. So in a typical Addisonian versus an atypical, so we'll kind of leave that out for a second, they have lost both. So if they're not losing potassium, if they're not putting out aldosterone, what are they going to do? They're going to have a high potassium and a low sodium, and they'll probably be dehydrated because they haven't been able to keep their blood volume up. And so that's one way. If they've lost their steroids, so there's a couple of things that happen. They have a low cholesterol because they're not taking care of fats, right? They can have a low blood sugar. And they definitely are going to have trouble with their blood sugar. I hope I didn't say blood pressure. They're certainly going to have trouble with their blood pressure. There's another thing that you see on the CBC, and that can be lack of a stress leukogram. And stress leukogram is what you think about cortisol stress. So that's when neutrophils are up and eosinophils are down. And so what we find is that they don't happen that way. And so you'll have low neutrophils and high eosinophils. And so that's another sign that many times we'll see with Addisonians. But that can be hard because that could be related to sepsis. So a typical Addisonian will show up in shock, lack of volume. They will maybe have a low blood sugar and a high potassium and a low sodium. And so people talk about a sodium-potassium ratio. And if it's less than 19 to 20, that's very typical of that situation. Now, an atypical Addisonian generally is one who is fine on mineralocorticoids but has lost cortisol. So you won't get this stuff here of a typical Addisonian. You'll just get the stuff here. Plus, now you start to notice a lot of these guys have chronic GI issues, like GI bleeding, intermittent vomiting, because of how important cortisol is for gut growth. And so that becomes a little more apparent. And that's why a lot of people run basal cortisols to screen for Addisons on some of our GI patients. It's because they're trying to see, okay, is this the atypical Addisonian that I'm going to have trouble checking because maybe they don't have it so bad that their sugar's low. Maybe there's no clues on the rest of the blood work. And there are a few that will show up that way before they get into super trouble. But some of them will show up as actually look like they're HGE, very sick HGE. Or they're sick with something sicker than they should be. So that's a general way that we sort of talk about Addisons. When we talk about Addisons as far as testing and treatment, we can go into a lot further. But this is a pretty good start for just Addison's disease.